Greetings, everyone. Welcome to the Pan American Health Organization and the World Health Organization's webinar, where we focus on ending the acute stage of the pandemic 2022. And we take a very close look at the state of the COVID-19 response in Barbados and the Eastern Caribbean countries. I am Nicola Barreto, your moderator for this session. Thank you so much for joining us. Our panelists for this webinar are Dr. Itadis Gibre. He is the Pan American Health Organization WHO representative for Barbados and the Eastern Caribbean countries. Dr. Prabhjot Singh, advisor, health, surveillance, disease prevention and control. Dr. Maria Cecilia Acuna, advisor, health systems and services. Dr. Lionel Gresh, a virologist and laboratory specialist. Dr. Darlene O'Meara Taylor, advisor, family and community health. Dr. Karen Paulson, advisor, climate and environmental determinants of health, and Patricia Cabrero, administrator. In 2020, when the pandemic struck the majority of the population, including myself, we believed that there would be some light at the end of the tunnel, possibly in a couple months, at least by the end of the year. That did not happen. And here we are in 2022, still battling, facing variants and doing our best to reach vaccination targets. Unfortunately, many millions of lives later. What is the plan? How are we going to get there? Well, that is the reason for this session today, and I'm going to quickly outline what the objectives are. And the objectives are basically ending the acute stage of the pandemic in 2022, letting you know the state of COVID-19 in Barbados and the Eastern Caribbean countries. That way you can help and do much more. The role of public health and social measures to control SARS-CoV-2 virus in the ECC. We're going to focus on practical ways of improving COVID-19 vaccination coverage, doing our best to meet the global target. And we take a look at the role of the SARS-CoV-2 testing in the midst of the Omicron variant. So to get the ball rolling and taking the floor right now would be Dr. Itadis Gibre, PAHO WHO representative for Barbados and the ECC. And he is going to actually focus right now on ending the acute pandemic phase to sustain the control of COVID-19. Dr. Gibre, the floor is yours.
Thank you very much, Ms. Barreto. Your Excellencies, Ministries of Health, Chief Medical Officers, ladies and gentlemen who are invited and participating in this webinar, and best wishes to you and your families for 2022. The overview of my brief introduction and welcome is on the following 3 points. So what are the factors continue to drive the SARS-CoV-2 circulation and what are the impacts? What is ending the acute emergency of COVID-19 means to all of us? And then the third one is that how to achieve and sustain COVID-19 disease control in each of those countries and territories in the Eastern Caribbean. The next slide, please. As you know, there are some factors that continue to drive the SARS-CoV-2 circulation and the impact in society and communities. What are the driving factors for the transmission? The virus continues to evolve, resulting in more transmissible variants from Alpha. Now we have reached to Omicron. The Delta wave was one of the largest wave we had since the summer last year. And then late in December and then in the fall, we have the Omicron. And then this kind of viruses, this change in the virus characteristics, the variant and immune evasion will continue to drive the transmission. The other one is that the population level. What is the population susceptibility from the lack of access to vaccine or from vaccine hesitancy? There are some studies in our region which were recently produced and shared. The other is that the waning of immunity following infection or after vaccination. That also continues to drive by having more susceptible population. Inappropriate use of or inconsistent use of proven public health and social measures, which from use of masks and then hand hygiene, ventilation, etc., and also social distancing and physical distancing, which we are mentioning. From there, there are a lot of social mobility and social mixing continuing, and then this also drives the transmission. Last but not least, misinformation, disinformation, and politicization of COVID-19, and also the false narrative in society and the communities. On the other hand, there are some the drivers of the impact of the SARS-CoV-2. The vaccination coverage, the higher the vaccination coverage, the lower the susceptibility and impact in our economy and society. So children and others could also go to work, and then other people also, mothers and fathers, to go to work as well. The duration of protection against severe disease. The vaccines have been very efficient, effective, and then has reduced severe disease and death and infections in some instances. And especially following vaccination and or infection. What does that mean to all of us? Equity in accessing the vaccines and other treatments and PPEs and medical equipments, early diagnosis, and then availability of treatment in pathways to access hospitals. The other area is what would be the future emergence of and circulation of variants of concern and their characteristics, the transmissibility, the virulence, the ability to produce, to make disease, and the properties of immune escape, whether those variants are able to evade the vaccines. So the management of post-COVID conditions, or the so-called long COVID, as you know, between 10–15% of population may have this long COVID. So how do we deal about this? And then the capacity and agility to adjust when we have higher cases, and then when to reduce and adjust our public health measures. The next one. Is the general population in our countries now immune enough to continue and then have better engagement in society? From this study, from different studies, what we could conclude is that in terms of the population level immunity, as low as 4% in the Western Pacific region, and then as high as 83% in PAHO, high-income countries, there is a population level immunity from COVID-19. However, that also does not translate equal in all places. Even in our region, the Americas, there are some countries where the immunity level is as low as 25%. Next one, please. The other area is that there is a positive impact of vaccination on severe disease and death. If you look at on the left side of these graphs from United Kingdom, at the bottom, the green and the yellow one shows you the first doses on the top, and then individuals who have finished the second doses with the green one. So as the time goes by, the red ones, which is death, has been significantly reduced in the United Kingdom because of access to vaccination. On the other hand, when you look at in South Africa, the vaccination coverage, which is below 30%, still there were some changes in terms of mortality or death or severe disease from COVID-19. So there is an important message here. Vaccination significantly reduced illness and death from COVID-19. The other point is that vaccination also reduced onward transmission, but it's currently insufficient to bring down the transmission reproductive rate. That means we want to bring less than one person being infected from a contact of a person who is infected. Therefore, that's the most important number we have to look at when to change this pandemic from the current stage from the acute stage to a more controllable one. Next one, please. So countries have to face different situations. The previous strategies they have. their epidemiology in terms of the distribution of disease, who is affected, where and why, and the population, the demographic, it is young people versus older population with chronic diseases. And the vaccination level is very, very important. And then what is the population immunity level we have to look at? And then access to vaccines, access to life-saving treatments, the diagnostics and PPEs, the personal protective equipment, and then finally, the capacity to implement across all areas of the strategic plan we may have at countries. So we need to continue to work on public trust and societal compliance in order to change and to have a sustained COVID-19 control. Next one. So ending the public health emergency of COVID-19 in 2022 has 3 areas of concentration. The first one is that we have to reduce and control the incidence, the occurrence of SARS-CoV-2 infection. That has to be taken from the protecting individuals, especially the most vulnerable one, including healthcare workers. That also includes not only what is circulating, but upcoming new future variants. We have to have vaccines, second and third generation vaccines. We have to calibrate the public and social measures in all settings, in hospitals. Vulnerable population would be in nursing homes, in schools, in prisons, everywhere where we have business places and everywhere where people are interacting. And then clearly we have to support, we have to have supporting policies that is targeted and layered to be a comprehensive one. On the other hand, we have also to have preventive diagnostic treatment of the COVID-19 tools. This will reduce morbidity or illness and then reduce death and the long-term consequences of the infection to the minimum. For that, our first goal is that to make sure by June, end of June this year, 70% of our population in each of those countries, in all countries, have to be vaccinated. And then definitely we have to have a better understanding of about treatment, and then we have to protect healthcare workers. So by doing this nationally and internationally, we can bring the change which is needed on health, the economy, the politics, the risk tolerance, and then the human rights also, acceptance of our public health measures. Next one, please. So this is a little bit busy, but we have to mention 3 things on this one. We have to reach the population who would be targeted for these interventions everywhere. The second one is that we have to calibrate our public health and social measures. The third one is that the communication is that it's very important to engage, empower communities, and enrich the knowledge and the ecosystem. We cannot win this battle unless otherwise we have the right information, the right place to the right population. We have to coordinate our work. There should be investment. We have to scale up and deliver the right interventions everywhere. And then we have to have equitable access to all life-saving interventions. Again, it's very important to communicate and then counter false information in order to build resilient health systems and then strengthening the communities, and then to work and to track the virus and its impact on our population. I'll stop here and I thank you very much.
Thank you very much, Dr. Gibre. Very informative. And I know you will be back at some point in time for questions and answers. Dr. Gibre, focusing on ending the acute phase of the COVID-19 pandemic. For those of you just joining us, I know a few of you came on just a little while ago, maybe in the middle of Dr. Gibre's presentation. Welcome once again to our webinar where we focus on ending the acute stage of the pandemic in 2022. And we take a look at the state of COVID-19 in Barbados and the Eastern Caribbean countries. We will take your questions. We have 2 question and answer sessions. We will do that after the next presentation, and then we'll do it closer down to the end of the webinar. So I'd like to take this opportunity at this point in time to welcome Dr. Prabjot Singh and also Dr. Maria Cecilia Acuna. Dr. Singh is advisor, health surveillance, disease prevention and control. And Dr. Acuna, she is advisor, health systems and services. Welcome to the both of you. And they will focus on the epidemiology of the Omicron wave and the disease profile in the Eastern Caribbean countries. Doctors, the floor is yours. Thanks.
Thank you, Nicola. I'll share my screen. So I'm going to talk about the COVID situation in EC, Barbados, and French departments. Generally speaking, the current global situation is that there are more and more cases being detected every day, every week, and the rate of increase is hitherto much faster than what we've seen any time in the last 2 years. Just in the last 1 week, we've seen at least 21 million new confirmed cases across the world, and approximately 50,000 new deaths were reported due to COVID-19 in the last 1 week itself. So you can see the magnanimity of the situation is still not declined, although we keep on saying that Omicron has been a milder disease, but in terms of absolute numbers of people getting succumbing to the disease, it's still a significantly high number. In terms of where is Omicron mostly affecting, if you look at this graph in the different colors which represent the different WHO regions, most of them have been reporting an increase, including the Americas, which is in the yellow, the European region, which is in the greens, as well as other like Southeast Asia, CRO, Africa, and etc. Where is Omicron present right now? Well, by the 11th of January, it was as widespread as this yellow-brown color that you see on this map, and it's across the regions, across all countries. We have now been able to verify that the Omicron is present, and a few of the countries which have still where we are on that particular day, it was under verification, and in some where the capacity may not exist, it has not been present, has been not reported. It does not mean it is not there. It's just that their presence has not been reported to date. So right now, Omicron is present in almost all countries of the world, and it is replacing Delta almost everywhere. Most of these countries, which you see in this dark teal color, are countries where Omicron has taken over. If you look at the amount of estimated Omicron prevalence on a scale of 0 to 100%, most of the countries in the Americas now are of the color which as almost bordering 99 to 100% of the cases being due to Omicron. This was the situation as of 10th of January. And of late, if you look at this graph, which is a little bit more colorful, look at the red around here, which signifies Omicron, and this greenish blue, which represents Delta. And as the years have progressed, as the time has progressed, early January 2022, we are seeing more than 60% of all samples being submitted to GISAID are currently all Omicron. And that just goes on to reflect what has already been, we have moderate evidence to support that Omicron is replacing Delta in most countries, in most places, and that is probably what we will be seeing going forward in almost all other countries, where it is still not the dominant variant. What's happening in the Caribbean, in the ECC, Barbados, and FDAs? The COVID-19 incidence has been increasing. This over here represents the weekly incidence of COVID-19 reported cases by each epi week. From 46 to 52 was the last year, and 1 to 23 is is this year, 2022. And as you might see in almost all the countries, as the color goes from green to yellow to orange and red, the incidence is only increasing. You might see that the incidence is much, much higher in, say, French Guiana, Martinique, Guadeloupe, the 3 French territories or French departments. But that is also because the diagnosis and testing in these countries or in these territories is the highest compared to some other countries. So perhaps that is what is being reflected over here. Nonetheless, compared to almost all the countries in the previous episode, in the previous periods, you can see the green has converted to yellow, reds, and oranges, and now reds. While in some countries we continue to see an increase, namely Antigua and Barbuda, Barbados, you continue to see an increase up to week 3. Dominica, there's sparse data from week 3, but what we know is that the increase is continuous, as well as in Martinique, where the incidence has only been increasing. On the other hand, there are 2 countries where it seems like either the incidence is declining or they've reached a level, a ceiling effect, perhaps. Grenada, where almost we're seeing the number of cases to have more or less stabilized, as well as in Guadeloupe, where the cases seem to be declining initially, but it's still early time to say that they're declining per se. In other countries and territories, St. Vincent and the Grenadines, it seems the number has declined, but this is a false decline. This is primarily because the country now uses RDTs as also confirmatory diagnosis, while the data for week 1 and before shows only PCR positives. Sorry, all of this is PCR positives, but from week up till week 1, it was only PCR positives, and very few cases now are being detected by PCR, but most of the cases are being exclusively diagnosed by RDT. So perhaps this lower prevalence over here, lower incidence is not what we're saying. But if you look at the RDT values, even they are now started to decline. St. Lucia seems like they are declining, but still early times. Anguilla, definitely a decline up to 5.5, but the data has been sparse of late, and so we just not yet confident as to the decline in that country, in that territory. And Montserrat, it seems it's declining definitely. Again, data is sparse, so we're just waiting on more data for this week so that we can probably say that this is declining. As well as in case of the British Virgin Islands, we still don't have data for week 3, so we can't really comment upon it. And 2 countries where we definitely see that a peak has been reached and the number of cases are now only on a decline is St. Kitts and Nevis. They reached the top. Early January is when they reached their peak, and now they've the number of cases have declined, as well as the testing rates. If you look at the positivity rate, that also has been declining, as well as in French Guiana, you see a substantial decrease. Now, going to some of these countries, some specific countries, just to give you examples of what we are talking of. So in Antigua and Barbuda, this is going to be the standard slide. You would see it for other countries too. The yellow signifies the incidence. The blue signifies the testing positivity rate on this axis, while the graph below shows number of people hospitalized on any given day. So if you look at Antigua and Barbuda, the coverage, the coverage for fully vaccinated is about 60%. And consequently, if you look at how the number of cases versus hospitalization rates have varied, you look at the Delta wave, the number of on any given day, there were almost 50 to 60 people who were hospitalized. However, in the current wave, you see much less hospitalizations, and perhaps the vaccination rate has something to do with it. On the other hand, if you look at French Guiana, the number of cases had increased at a very fast clip, as well as if you look at it, the number of hospitalizations also reached a peak with a definite lag of about a week to 2 weeks, and now they're on a decline. However, if you look at the number of hospitalizations, it was much higher than what was reported in the Delta phase and the Delta wave. So again, perhaps it's also relevant to mention that the coverage of fully vaccinated is only 26% compared to Antigua and Barbuda. So the number of people who are being hospitalized is not necessarily a function of whether you have Omicron or Delta, but also as to what is the total number of people who are being vaccinated. And that is pretty much evident in using these 2 slides, countries as examples. Another example could be St. Vincent and Grenadines. The coverage is about 25%. The yellow is the incidence. You look at the red line, that is the PCR plus RDT incidence, which is more reflective of what the situation is of late. And you look at the incidence, it's going down. The positivity rate, however, seems to be going up, but that is only PCR positivity rate. We don't have RDT data from them, so we can't really comment upon that for now. But you look at the hospitalization rate, and it is more or less very constant. It hasn't really declined as much even between the two waves, and of late has been increasing. Perhaps we might see more hospitalizations in the future, but it's still early period to say what they've reached a peak or not. But definitely vaccine coverage has definitely a lot to do about how many people are hospitalized in getting given country. And the last example I'd like to show for you is Barbados. Barbados, you look at the incidence. Here the incidence is switched. Incidence is in lines, whereas the bars are test positivity. Barbados does share data by age group. So you look at the red line, which is the adults, while as the blue is the children less than 18 years old. And both age groups, you see the incidence has been rising very steeply of late. And the positivity rate today of the last 7 days has been above 25%. So every 1 person of every 4 people tested, 1 of every 4 person is turning out to be positive. That is the intensity of transmission. And perhaps that is that is where pathogenomically where we are right now. In terms of people hospitalized, what we use over here for hospitalization is what Barbados reports as the primary and secondary isolations, which we consider as moderate to severe disease. And if you look at the blue dots, those blue dots signify how many people have been hospitalized. So of late, we have been seeing an increase in the number of people being hospitalized. It has still not reached the peak of say 120 or 130 people that were being hospitalized during the Delta wave. And perhaps that is because the vaccination coverage is 51%. But again, the case incidence is still rising. So perhaps we will see an increase, and we'll see what would be the topmost. Now, special case in case of Martinique. Martinique presents its data and gives the incidence rates by age groups. So for instance, this is the graph where you can look at the age groups, 0 to 9 on the bottom, 90 plus on the top. Excuse me, it's in French, so if you don't speak much or don't read it, I'm just trying to focus on the numbers and the colors. So if you look at the colors, the darker the color, the higher the incidence. And as we go into early January, this is around late 2021. And early January, the incidence was the highest amongst the adults, as well as in the younger age group population. But if we were to look specifically in the children age groups, you could see the incidence is also very high when you try to divide it amongst different smaller age groups. So for instance, 0 to 2 and 3 to 5 years, the incidence is higher than what it was before, but it is the highest in the 15 to 18, 15 and 11 to 14 age groups, which is the teenagers. Perhaps also because most of these age groups, the vaccination rate, especially for the ones who are less than 12 years old, is almost next to 0. So perhaps the susceptible population is quite high in that age group, versus in other age groups that the population is not as high. Nonetheless, when you look at how many people are being hospitalized vis-a-vis age and how many people are in the ICU vis-a-vis age, you see that most of the people, or in fact, almost all of the people, are 20 years and above in hospitalizations and 20 years and above in ICUs. So it just points that although we are seeing a higher incidence in probably the younger age groups, the children, but that does not reflect, or that does not translate into a higher hospitalization rate or higher ICU hospitalization rate in Martinique specifically. And that could probably be the case with other countries in the Caribbean region too, but data at this level is not yet available from other countries to make an assertion. That's it from me. Over to you, Akunya.
Thank you, Prabjot. Brenda, I can share my my screen. Or if you have it there, if you can share it for me, thank you so much. Okay, so we are going to focus a little bit in the disease profile now. As you may all know by now, Omicron shows preference for upper respiratory tract infection, which means that the symptoms of the disease are more similar to other upper respiratory infections with cough, fatigue, congestion, runny nose, and less on the side of the high fever. And importantly, Omicron doesn't seem to produce a loss or change in smell or taste. This is not only important for the symptoms, but the fact that Omicron appears to show preference for infecting and replicating in the upper respiratory tract compared to Delta may confer a transmission advantage to the virus, and maybe that is why its transmissibility is much higher. But also, maybe this is why Omicron appears to have decreased ability to infect the lung tissue and to induce less pneumonia. So these are the differences we are seeing in the clinical course of the disease. So we shouldn't see as much pneumonia with Omicron as we saw with Delta and other variants. The next one, please. Also, Omicron has reduced risk of hospitalization compared to Delta. There is a decoupling between case reports and hospitalization. So we are seeing that although Omicron is highly transmissible, it seems that less people are hospitalized because of Omicron. However, the large number of people being infected with Omicron translates into significant number of patients requiring hospital admission. So let's not be blinded by the fact that Omicron might not cause pneumonia and might not be as severe in terms of inducing hospitalization, because this is not to be understood as this disease is milder. Next one, please. The fact that Omicron induces less hospitalization than Delta variant does not mean Omicron is mild. The disease caused by Omicron is not mild. We are seeing an increase of deaths in all countries of the American region. You have the statistics there. So it is important that all of us realize that Omicron is not a common cold. And it must not be considered that, because we would be making a huge mistake. Omicron is not a mild disease, and it can kill people. Next one, please. So who are the people at risk of dying from this disease, from Omicron? Older people and those with underlying conditions, they remain at risk. Older people continue to be at greater risk for developing the severe form of the disease, and those with underlying conditions, such as unvaccinated people, people with obesity, hypertension, diabetes mellitus, cardiac disease, chronic lung disease, HIV, pregnancy, which is not a disease, it's a condition of life, but makes women less, it seems that it makes women less strong to face the disease and more prone to acquire the severe form of the disease. So the message here is that Omicron can still be lethal among the unvaccinated and immunocompromised, and it can still be lethal for pregnant women. Next one, please. How about therapeutics and Omicron? Omicron, as you may know, has multiple receptor binding domain and N-terminal domain mutations. This is actually the big difference that Omicron has. It has a lot of mutations associated with resistant to neutralizing antibodies. What does this mean? It means that some monoclonal antibodies that were being used effectively in the treatment of this disease with the Delta variant may not be active against the Omicron variant. And this is very important from the clinical perspective. So some preprints and data from respective manufacturers suggest that monoclonal antibodies, silgavimab and tixavimab, as well as bamlanivimab and etesevimab, and Regencov, which is casirivimab and imdevimab, are partially or fully inactive against Omicron, which, of course, calls for a review of the treatment protocols in all the ICUs. Sotrovimab, on the other hand, appears to retain neutralization activity on high-risk, non-hospitalized patients with mild to moderate COVID-19 within the first 5 days on the onset of the disease. So this is important. So if some of your clinical teams are using sotrovimab to prevent the severity of the disease in high-risk people already infected with COVID-19, of course, in the first 5 days of the disease, they can continue to do so. Interleukin-6 receptor blockers, such as tocilizumab, and corticosteroids, such as dexamethasone, are expected to remain effective in the management of patients with severe and critical disease, which is the other end of the disease. So for now, the 3 pillars of pharmaceutical treatment for patients with severe and critical COVID-19 continue to be oxygen, corticosteroids, and interleukin-6 receptor blockers. It is highly recommended that interleukin-6 receptor blockers are used along with corticosteroids in the critically ill patients. So we do have, with Omicron, at least 2 set of medicines that are useful. One, when the disease has just started within the 5 days of the disease, for those high-risk population who are not yet hospitalized, to prevent those people to go into the severe form of the disease. And this medicine is sotrovimab. Sotrovimab is still useful for this. And on the other end of the disease, when the patient is already critically ill, in the ICU, intubated with mechanical ventilation, we continue to use corticosteroids and tocilizumab, which is an interleukin-6 receptor blocker, along with oxygen. Next one, please. How about Omicron and long COVID? Around 10 to 30% of COVID patients suffer from long COVID. Long COVID can happen to anyone who has had the COVID-19 disease, even if their illness was mild or if they had no symptoms. It is too soon yet to determine whether Omicron can cause long COVID, but there is no evidence on the contrary. The more people are infected, the higher the possibility some of them will have long Omicron. So the higher transmissibility of Omicron indicates that we can see more people with long COVID. Next one and last. Oh, I think this is, I see that one. So yes. So for the future, for the next future, once the acute stage of the pandemic is passed, from the clinical perspective and the organization of health services, it will be very important to look into how are we going to organize our health services to keep on doing recognition, research, and rehab for post-COVID-19 condition or long COVID. So all future scenarios, we need to manage and care for patients with long COVID. And my last one. So again, from the clinical perspective, we need to plan for the future with good confirmation technologies for making the diagnostic of SARS-CoV-2 infection, assessing the symptoms, risk factors, and severity, and most of all, responding with appropriate care and treatment for the COVID-19 disease, depending on the variant that is present, with the medicines that are most appropriate for each variant, and to evaluate clinical response and recovery. So this is the methodology we are proposing as WHO to face the clinical course of the disease and the treatment of our patients from now on, because early clinical care will save the lives of our population. And I will stop here. Thank you.
Thank you very much, Dr. Acuna, and of course, Dr. Singh. They focused on the epidemiology of the Omicron wave and the disease profile in the Eastern Caribbean countries. I've got one more presentation before we jump into your questions and answers, but I also just want to remind you of the objectives of this webinar. We're focused on ending the acute stage of the pandemic in 2022, and also the state of COVID-19 in Barbados and the ECC. We're taking a look at the role of public health and social measures to control the SARS-CoV-2 virus, focusing on practical ways to improve the COVID vaccination coverage, meeting that global target. And we're taking a look at the role of the SARS-CoV-2 testing in the midst of the Omicron variant, which brings me to Dr. Lionel Gresh. He is the Pan American Health Organization, World Health Organization virologist and laboratory tech specialist, I should say. Dr. Gresh, welcome. The floor is yours.
Thank you, Nicola. Good morning, everyone. And it's really a pleasure to be with you today. So I'll be sharing some thoughts on the testing of SARS-CoV-2 in the face of the Omicron wave, and maybe also in the face of other future variants that might arise. And basically what would like to do is to touch on three main aspects. The first one will be just simply the detection of SARS-CoV-2 in the current epidemiological context. The second will be specific tools that are useful to detect specifically Omicron or a specific variant. And then more generally, how we should see testing in this current wave of Omicron, and in particular touching on testing strategies. So just before I dive into these more specific aspects, I just want to remind everyone what we're discussing here. So these are, as with SARS-CoV-2 and as with any other virus, the assays we have to detect are fall into two categories. The first one is virological assays that basically directly detect the virus or one of the components of the virus. Here we can detect either the genetic material, which is RNA for this type of virus, using a molecular test or RT-PCR, and that's considered today the gold standard for detection of SARS-CoV-2, or we can detect viral proteins, also known as antigen, using immunoassays, including lab-based ELISAs or rapid diagnostic tests. On the other hand, we have serological tests that, for many reasons that I won't have the time to cover here, are not really useful to confirm active infection and are not used in the confirmation of COVID-19 cases. So what do we know about these currently recommended methods for diagnosis and Omicron? In terms of the molecular test, RT-PCR, we've seen no impact on the recommended RT-PCR protocols, and I've listed here some of the ones we've been using in the region. The original Charité Berlin protocol that has been recommended for what we call universal surveillance of SARS-CoV-2. Also, one assay that some of you might have heard about recently, which is developed by US CDC, a multiplex for the simultaneous detection of influenza and SARS-CoV-2. And actually all of the WHO listed assays. So no impact on the detection, on the performance of these assays. Some of the multi-target assays that detect specifically the S gene might show an S gene target failure, what we basically not a loss of the detection capacity of that S gene because of the accumulated mutations in Omicron. But this is really not a problem because these are multi-target assays. So the other parts of the assays will still function correctly, and they actually can be used as a proxy for some of the Omicron sublineages. In terms of antigen RDTs, the picture is a bit more complicated because it's not as easy as for RT-PCR assays to validate all the antigen RDTs that are available. We have preliminary data showing similar performance when we use viral cultures of Omicron versus Delta and other lineages. But really what is key is our prospective clinical studies, which are ongoing, in particular for tests that are listed in the WHO emergency listing. So here we have no doubt that the antigen RDTs work. The issue would be if there is a slightly decreased sensitivity with Omicron, and this data will be coming on really soon. So now on how do we specifically detect Omicron and differentiate it from other variants? This is done as for any variant, really through full or whole genome sequencing. So really the identification of a specific lineage or a specific variant requires that full genome sequencing capacity. This capacity in the region is available, among others, at UWI in Trinidad and Tobago, that has been serving as a PAHO sequencing reference lab and also working with CARFA on that function. Now also at the CARFA laboratory also in Trinidad. And some countries are working and upgrading their facilities to include that capacity. An example is St. George University in Grenada. Alternative approaches to whole genome sequencing are sequencing targeted regions of the genome using more traditional sequencing techniques, and screening for specific mutations that are found in variants by RT-PCR. So these screening RT-PCRs have advantages: shorter turnaround time. They're easier to implement in labs that have that PCR capacity but no sequencing capacity, and there are many assays to choose from. These advantages are that they're not confirmatory because variants are really characterized by a number of mutations that are found throughout the viral genome, and that the mutations we're detecting might arise again through conversion evolution in future lineages. I'll just briefly touch, without getting too technical, on one of these screening RT-PCR assays that we've been using and recommending in the region. Is an assay that was initially developed to track gamma emergence and spread in the Amazonas. It detects a particular mutation in what we call the NSP6 protein of the virus, this being the viral genome. Again, without getting too technical, that protocol is able to detect two specific deletions, one that is present in alpha, beta, gamma, lambda, and two of the Omicron sublineages, which are called BA2 and BA3, and another one that is present in the original Omicron lineage, B11529, and in the BA1 sublineage, which is the one that is most commonly found in the Americas. Those deletions are not present in Delta, Mu, or other VOC, VOI. So this can be used to screen and have an idea, at least initially, whether Omicron might be present. And now to the last point I would like to discuss, and probably the most important, is which testing strategies should be implemented in the context of Omicron circulation. And as you probably aware, because you're facing that already in some of the countries and territories. The main challenging is the significant increase in testing, and thus in cases and in testing requests. And also this is accompanied with a shift of the burden to the first level of care. So in that context, we really need to expand the testing capacity at the first level of care. And the easiest way, not the only, but the easiest way to do that is through the implementation of antigen RDTs. It's important to mention that in general, there is no need to confirm antigen RDT results using RT-PCR, because really those tests have a good specificity, so they few of false positive results, and they have a good sensitivity for persons that are that have high viral loads and thus are potentially the most infectious one. I just want to remind everybody that high quality WHO recommended antigen RDTs are available through the PAHO strategic fund mechanism at globally negotiated prices. So the two that are most being that have been most commonly used in the region are the SD Biosensor Standard Q and the two Abbott PanBio tests, one that uses a nasopharyngeal swab and the other a nasal swab. So in this context, it's really important, in the context of Omicron circulation, it's really important to prioritize which samples are to be tested. And I want to point, and I'll include the links in the chat, to two documents. One recent alert from PAHO on the rational use of COVID-19 diagnostic tests that really calls for appropriate measures so that testing capacity is used in a rational way and ensures the provision of significant testing for surveillance and medical care. And also a document from WHO, which interestingly is an older document from June of 2021 on recommendations for national testing strategies. And I think this is an important point to highlight, that this idea of having a national testing strategy that is in accordance with the installed capacity in the country is not something new. It's not something that comes with Omicron. It's really something that we've been working on since actually the onset of the pandemic to really ensure that the testing we're doing is the testing that has the most impact in terms of public health. And what's interesting in this document is you have ideas about how to prioritize testing, and also ideas about alternatives to not testing when testing capacity is not enough. So highest priority would be symptomatic health or care workers, individuals meeting the case definition for COVID-19 and requiring an admission to a healthcare facility. So this would be your highest priority for testing. And then you could, at lower priority, recommended to test to test symptomatic healthcare workers that have been identified as a contact, or individuals that have met the case definition for COVID-19 that have mild disease, so they do not require admission, but might then require it so at a later point. So that's a lower priority. When you have identified a potential outbreak or cluster in a specific testing, an alternative to testing everybody will be just testing a subset of cases, and this could be done, as I mentioned, when you have identified a potential cluster, or in closed settings, including school, hospitals, and long-term living facilities. And the situations where testing is really lowest priority, or actually not required, is asymptomatic contacts of confirmed and or probable cases, because in that case you can proceed with quarantine without requiring testing. recovering patients, so testing to discharge people from isolation is not recommended and has not been recommended for the past 18 months, and general testing of the asymptomatic individuals. Just want to mention that one addition to that list of priority groups in two recent documents, one that I just mentioned on the rational use of COVID-19 tests, and one of the organization of health services in the context of Omicron circulation. And I also share the links to those two documents. So one priority group also could be patients who need to be hospitalized for any reason, so that we protect the healthcare workforce by decreasing the potential of transmission in healthcare settings. So with that, in terms of conclusions, really it's important to note that the emergence of mutations and variants is part of the viral evolution process, and the higher the transmission rate are, probably the higher the probability of new mutations and new variants appearing is. That there is no silver bullet for COVID control. I think Dr. Gebre alluded to that in the, or pointed to that in his in opening presentation. We need, of course, testing, but we also need surveillance in general, public health and social measures, vaccinations, and many others. In terms specifically of testing, again, the main message would be to expand testing capacity using antigen RDT as a main tool, and having clear testing strategies that are aligned with the testing capacity, with a clear prioritization criteria for moments where testing is not sufficient to cover for all testing that is requested. So with that, I'll thank you all for your attention, and I think I'll give back the floor over.
Thank you so much, Dr. Gresh. For those of you just joining the webinar, that was Dr. Lionel Gresh, virologist and laboratory specialist at the Pan American Health Organization, World Health Organization, and he focused on SARS-CoV-2 testing in the face of Omicron and other possible variants. Well, it's that time. We are going to open the floor to your questions. We have 2 question and answer sessions, and this is the first. Of course, we've got the question and answer box up below. So feel free. We'd like to know what you want to know. I'm sure you've got many questions, given the phase that we're in right now and the issues and challenges that we face. So if you want to speak to Dr. Gresh or Dr. Acuna or Dr. Singh or even Dr. Gibre, and possibly or other panelists coming up a little bit later on. So I see I've got a question here. The first question I see comes from Melinda Brown, and she says, is there any relationship between the vaccine distribution with the mutation of the virus, since the more vaccines administered worldwide, the more variants mutate? And I'm guessing that is the gist of the question, Melinda. I'm not sure who would want to take this, whether it be Dr. Singh or Dr. Acuna or Dr. Gibre or even Dr. Gresh. Dr. Gibre, you're going to take this one?
Lionel could start. Yes, I will answer as well.
Okay, thank you very much for that question. So, interestingly, all 5 variants of concern that have emerged so far, that being Alpha, Beta, Gamma, and Delta, and Omicron, have all emerged in the context of low vaccination population. So none of those have been driven by a high vaccination rate. The last one being South Africa. In South Africa, when Omicron emerged, the percentage of the population that was vaccinated, fully vaccinated, was less, or around 30%. So certainly in the future, this might be an issue, but currently we're not seeing mutations or variants emerging under a selective pressure imposed by a high coverage, vaccine coverage rates. So that would be my answer. Over.
Thank you, Dr. Grash. Dr. Gabriel?
Yes, to add to that, it's a correlation what we are seeing. Yes, of course, we're almost 9 billion doses of vaccines have been administered, and it is skewed. It's not equal. It's not all over the world. And still, in Africa, for instance, we have as many as 85% of the population of 1 billion not vaccinated. So there is a lot of gaps in terms of the vaccine distribution. So when we have a lot of people not vaccinated, globally, we are because of infection and because of vaccine, we may have immunity reaching about 51%, half of the world population. So we have not reached that level to say that we have adequate coverage from the vaccine, and then that would have resulted in, as Leonel mentioned, the evasion or escape from those vaccine distribution. So it is the contrary, it is the opposite. And what we see currently is that the mutation exists because of low coverage of vaccination. The future is different. We have to continue and then also improve our vaccines and then for their effectiveness to make and then have a longer protection from severe illness, severe disease, and also death. The vaccines are not also protecting infection. So we have to have also better vaccines which prevent infection as well. Back to you. Thank you.
Dr. Gabriel, on that note, I don't know if you want to take this one. One of our attendees has asked, how soon after you've recovered from Omicron can you get reinfected? Do you want to take that one in terms of a broader base?
We have a discussion later on vaccines, so let's hold that one and then we're going to move. A very good question.
All right.
I don't know if Leonel will be staying with us if you want to answer it right now. Otherwise, we have more presentations to come.
Okay. One more question.
So.
Okay. One more question though. Donella Huston, she says, in the Caribbean, there are very few vaccine choices. Do you believe the lack of vaccine choices are affecting the increase in vaccine hesitancy? Are there very few vaccine choices?
Dr. Omer is there, and she has also a presentation. I could invite her. You could invite her to speak first on that.
Okay, all right. So given the basis of this question, what I would like to do now is to invite Dr. Omer, and that is a question that we will answer as well. Alfred Athill, we will also answer your question after Dr. Omer's and Dr. Paulson's presentation. All right. Thank you. Keep the questions coming. Thank you, Dr. Gibre. I would like to invite now Dr. Darlene Omer Taylor, and she is Advisor Family and Community Health, and she will focus on COVID-19 vaccination coverage to meet the global target. Dr. Omer.
Good morning, everyone. So I'm going to continue talking a bit about the global target I was mentioned earlier. We are in a position now in which we need to revise our targets and make some adjustments. The next slide, please. Following the guidance that WHO issued in October last year. And this is the strategy to achieve global COVID-19 vaccination. You may recall that at some point we were targeting to have 10% of the population vaccinated, and this is all age population eligible for vaccination, of course, but we're looking at the coverage of the total population. By September 2021, some of our countries met that target. Then we moved toward the 40%, which we were supposed to achieve by December 2021, and I'm missing the number 1 there. And now we have the challenge, which we knew about last year, as I said, October, of 70% coverage with COVID-19 vaccines by June 30th. This is like very short time. And this is based on that we now have more access to vaccines, and we were in much better position than where we sat early last year. And also making reference to the previous question, we have so many other options as well. In the Caribbean, most countries are delivering 3 and 4 different types of vaccines. And these are all approved vaccines. And I would say they are the very most demanded globally. The next slide, please. So where are we sitting now with this target? And if we look at this slide here, and I'm using a slide that my colleague Prabjot prepared, and you could see the coverage in the bottom part of the slide. You can see the percentage what each country has, and of course you can see Anguilla is one of the highest coverage countries. They are currently above 60, but still the second line there, the dotted line, is showing the 70%. And this is giving you a reference of how far they are from the 70%. The yellow line is showing you the first doses applied. So if they are able to get the second dose to those persons by June 30th, obviously they would be much, much closer to the 70%. The second runner up there, you can see Antigua as well. So the yellow line is first dose, the green is those persons fully vaccinated, and that's the one we use to measure coverage. However, when we look at the 70%, you can see farther down in the table, some countries are very, very far from that second dotted line there, which is the 70%. And what we have on the right here of this table is basically the additional effort that countries would need to do in terms of increasing their vaccination rate to meet the 70% target by June 30th, 2022. And on the other side is how many doses of vaccines, independent of the type, and this was estimated on a 2 doses vaccine, how many vaccines they would be needing to reach the 70% target. So if you look at my next slide, what I attempted to do here, you can see in the first column are the countries. These, the ones in blue are the AMC countries, meaning the countries that receive free vaccines from the COVAX facility. And then the percentage of coverage that each country have. And here I'm narrowing down to the Eastern Caribbean countries only. And the third column is the interesting one, because this is saying, it's giving us an average, and this average was taken from 1st December to the 24th of January. And it's giving us an average of second dose vaccines that the countries are doing daily. So if we look at Anguilla is doing approximately 6 second doses vaccination daily. However, in the last column, they need to reach 8 doses daily in order to reach that 70%. If not, they would take 211 days if they continue with that 6 daily vaccination rate. They would take 211 days to reach the target, which would be beyond the June 30th. If you look at Antigua, however, Antigua is doing approximately 94 doses, second doses daily, and they would reach the target in little above 3 months and a half, because they only need, if they continue with that pace, of course, because we don't know if something might happen and I hope not, the rate continues same, they would reach the target in 104 days. And that would be, I want to think, one of the countries that might have the most possibility. Because if we go further down in the table, there are countries that you can see, for example, and I'm just pulling for examples, right? Grenada, if they continue with that 44 second doses applying daily, they would reach the target in 965 days. So they need to boost up vaccination to 271 second doses per day, which is so much percentage above of what they're doing. That means moving from 44 every day to 271. That's a really, really strong challenges. The same, if you look at Barbados, Barbados is doing currently 184, but they will need to scale up to 350 doses per day. And you can see St. Lucia from 94 to 495 daily. So these are a really, really strong challenge that countries have. I would like to take note though, if you go back to the second target, which was the 40% by December, to Dominica. Dominica met that target, I believe, last week. So we now have 4 countries meeting the 40% target. However, now we're looking to the 70%. And if we look at this table, it requires a lot, an additional effort that countries will need to put in place to be able to meet this global target. However, we are very optimistic, and we know it's going to take a lot of additional planning and strategies for vaccine delivery. In the next slide, as I mentioned, we need to boost up some strategies, and the document speaks to some strategies. We need to monitor demand versus uptake. We need to commit to equitable distribution of vaccines, and we also need to revise and update our national vaccination strategies and policies. The next slide, to make it a bit more precise, we need to develop our COVID-19 national vaccination plan for 2022. I know most of the countries have started this. We did one for 2021, which the scenario was completely different to the scenario we're in this year. And in that plan, we have to include issues related to forecasting. We cannot continue to have vaccines expired before being delivered, but we also need to include these strategies to reach these highest priority use. And I'm going to talk about the highest priority use in a bit. And that, I mean, we need to consider some innovative way. We need to understand better what's related to vaccine hesitancy. And we know some countries are now moving towards house-to-house vaccination, doing, talking one-to-one with the user to explore their concerns and address those. And of course, we need to improve data quality, because all these tables and information presented earlier relies a lot on the country data that they are sharing with us. And we have some data missing, we have some coming late, and this is very important so we could better understand and support the response. And of course, the continuous capacity development to healthcare workers. Now, in my next slide, I want to talk a bit about, quickly, because I'm conscious of the time, about the roadmap for prioritizing. This was updated the 21st of January, a couple of 4 or 5 days ago. And what the roadmap is saying, what WHO and the SAGE is saying, the Strategic Advisory Group of Experts for Vaccines, they're saying that we need to focus on providing the primary vaccinations, increasing the primary vaccination series coverage rate. We know many countries are now pushing boosters, but what we're seeing is that once we reach a higher coverage of the primary vaccination series, it's had a greater impact on reducing hospitalization and death than increasing the booster dose coverage. The second thing that there's a lot of things, I've just pulled out 2 things here, that however, in the high priority use group, then we need to ensure boosters for this specific group. And in a context of limited vaccination, this group should be prioritized for the booster doses. The next slide, please. So pretty much this step 1, work with the older adults and the high risk group, and then the other adults, and finally the adolescent. But if you look on the next slide, please, you're going to see a bit what we're referring to. So now WHO has introduced 4 groups. So first we were working with high priority, medium, and low, but now we have this highest priority use group. And the highest priority group refers to the older adults, the healthcare workers, and the immunocompromised persons. And this is based on all the research that have been done. And we're seeing that this is the group that has at more risk of dying in the current context. And what happens is there was a lot of discussion as to what is older adults. And some people tend to cut off and understand that we're referring to above 80. And what we have to ensure with this group that they have the primary series, understanding primary series by these 2 doses, depends on which vaccine you took. And if you're immunocompromised, you still need a 3rd dose, an additional dose to consider you have this primary series, and then move them toward the booster. So this high priority group will need the primary series, the additional dose, and the booster. Then we have a second group, which is the high priority use. So you see the first one is highest and then high. And this we're talking with adults with comorbidities, pregnant women, teachers, persons with certain disadvantage financially, and of course, the migrant population is in there. And there, of course, we're focusing on the primary series and the boosters, and then the medium, primary series as boosters. And then if you look at the scale, what we're saying is the priority should be in this order. So this is one of the main tools that countries should be referencing when they're developing their national vaccination deployment plan and defining their strategies for vaccine delivery. The next slide, please. And just as an update now to close off this presentation, I just wanted to share that on January 21st as well, the strategic advisory group of experts issued the updated their interim recommendation for the use of Pfizer vaccine, and they have now approved the pediatric use of Pfizer vaccines, and this for children from 5 to 11. However, we need to be cautious that this vaccine is not the same vaccine that's being used for adults. It's the same Pfizer, but it has a different formulation, and the dosage is also different. You can see in the 3rd bullet, and the diluent is also different. So just a matter to share this. And so when countries are making the decision, they must be aware that the vaccines that they currently have in Pfizer is not the same one used for the 5 to 11. And I think, if I'm not mistaken, this is my last slide, and thank you.
Thank you so much, Dr. Taylor, for that very informative presentation. We will take your questions in a little bit. I've got to introduce Dr. Karen Paulson. She is Advisor, Climate and Environmental Determinants of Health, and also Ms. Patricia Cabral. She is Administrator, and they are going to focus on the Eastern Caribbean countries' contribution for COVID-19 and the response in the ECC.
Good morning, Nicola. Thank you very much. Can you let me know if you're seeing my slides?
Yes, we are.
Okay, thank you. So as Nicola said, we will be speaking to the response of the PAHO Office to the COVID-19 pandemic in support of our countries. And I'll share the presentation with our administrator, Ms. Cabrejo, who will speak to the financial implementation and the resources which are mobilized. Our response to the pandemic and the support to the countries was provided through under the Strategic Preparedness and Response Plan for WHO for COVID-19, which has 10 pillars. And this is under which we work. So it goes from pillars 1 to 10. The first one dealing with country level coordination, then risk communication, surveillance, and so on. And I will go through each pillar just to give a snapshot of what we have done. It by no means shows everything that this office has done in terms of the support to countries. So under pillar 1, at the beginning of the pandemic, we constituted our incident management support team, and we met daily and had virtual meetings with countries as we work to develop proposals for mobilizing resources to assist the countries. We also worked with the countries to develop their strategic preparedness and response plans, which were loaded to the WHO Partners platform as a means of also mobilizing additional resources. And we work with our other partners in the UN system under the multi-sectoral response plan and through the funding appeal. The response continues in terms of the constant meetings with countries to update and to monitor what is being done and to see how we can garner additional resources. Pillar 2 speaks to the risk communication area in terms of helping to debunk some of the myths and to promote the credible information. We produced and disseminated videos, posters, social media cards, and so on. And we also strengthened the capacities of health information units in some countries, such as St. Lucia, to produce and disseminate local materials. We engaged partners from various communities. So we had webinar sessions, meetings with the diplomatic community, with other sectors. We worked with the ministries of education. We also worked a lot with UNICEF in terms of developing some materials for the schools. We also worked with UNICEF in developing and launching the regional campaign for vaccines under the theme Vaccines Bring Us Closer, Choose to Be Vaccinated, and Share the Love, Get Vaccinated. And we also developed a series called A Matter of Fact, which deals with information related to vaccines. Several thematic webinars were conducted, from scaling up COVID-19 testing through to reopening of borders, and one held last December on looking at variants of concern from Delta to Omicron. Under pillars 3 and 4, where we provided support to surveillance and also to points of entry, we hired surveillance officers for some countries, data entry clerks, and the countries listed: Anguilla, Antigua and Barbuda, Barbados, Dominica, Grenada, St. Kitts and Nevis, and the British Virgin Islands. We also hired information technology personnel. So in total, we hired approximately 50 persons in countries to assist with the response. We also purchased equipment such as thermal imagers to be used at points of entries. And we purchased some vehicles for some countries: Antigua and Barbuda, Dominica, St. Kitts and Nevis, St. Vincent and the Grenadines, to assist in terms of contact tracing, moving staff to follow up on persons who were deemed to be COVID positive. We also purchased IT equipment such as laptops. Over 70 laptops were bought for countries, tablets, computers, printers, and so on. And under Pillar 5, we looked at strengthening laboratory capacity for the detection of SARS-CoV-2. Lab personnel were trained virtually and physically. Visits were made to some countries such as Barbados, Antigua and Barbuda, St. Kitts and Nevis, to help to build and strengthen such capacity. We also procured laboratory equipment and supplies such as PCR machines, extraction kits, gene expert cartridges, rapid antigen kits, nasopharyngeal swabs, and so on. Under Pillar 6, which deals with infection prevention and control, we did some capacity building. At the beginning, we were able to visit some countries and conduct training on the ground, like in Grenada and Dominica. Subsequently to that, we did some virtual training with a course for Antigua and Barbuda and Grenada. And we also purchased or procured some PPEs, such as surgical masks, gloves, gowns, and so on, to support that pillar. Under Pillar 7, which deals with clinical management, we conducted assessments of some isolation facilities for some countries, for Barbados, Dominica, St. Kitts and Nevis. And we also had some emergency medical teams deployed to Grenada and Dominica recently. And we also conducted an assessment of health systems and services to see how we could help them to better support the COVID-19 response, or the management, clinical management of COVID-19 patients. And we also purchased equipment and supplies, so ventilators, defibrillators, oxygen concentrators, and so on. And under Pillar 8, which deals with operational and logistic support, we worked quite a lot with the regional security system, the RSS, to move supplies, especially due to closure of borders and points of entries and so on. So that was a very, very big help for us with partnering with the RSS. And for Pillar 9, which is where we looked at maintaining essential health services, We looked at areas dealing with non-communicable diseases. So there was a launch of an online version of the chronic disease self-management course for persons mainly who couldn't access care, and nutritional standard operating procedures were developed and disseminated for use by health facilities in emergency settings. And finally, for pillar 10, which is a pillar that came on at the beginning of 2021, vaccines were addressed. Dr. Omer spoke to quite a bit of what was done with vaccines. So we worked with countries, provided technical briefings, helped countries to prepare for the receipt and delivery of vaccines. Trainings were conducted using various tools, such as the vaccine readiness tool, the cold chain equipment tool, assessment. And we also worked with authorities to support them in completing the requirements for COVAX and develop national deployments and vaccination plans. We also supported the digitalization of COVID-19 vaccine data and strengthened capacities on the use of new vaccines. We hired personnel in countries for data entry specific to vaccines. And we also procured some cold chain equipment, ultra low volume refrigerators, regular refrigerators, cold boxes, and so on, and facilitated the distribution of more than 200,000 doses of vaccines through the COVAX facility. So that's it for what we had done thus far for the pandemic, a snapshot, and I'll hand over to Ms. Cabrejo for the financial implementation.
Thank you, Karen. Last but not least, I will be presenting the financial implementation as well as the resource mobilization efforts in support to the COVID-19 pandemic. We know that without funds, much of the support wouldn't have been possible. Next slide, please. Next one. Okay, thank you. Well, thanks to the efforts of the organization in mobilizing resources to support the COVID-19 pandemic and the contribution of our long-standing donors, we were able to mobilize for the biennium 2020-2021, $8.8 million for Barbados and the Eastern Caribbean countries. As you can see in the graph, the biggest portion came from WHO of $6.6 million. These are donors channeling their contribution to our organization through WHO. Some are traditional donors and others are new donors wanting to support the COVID-19 pandemic. The rest of the contributions came from the United Kingdom, USA, and Canada through their different financial agencies. Next one, please. Thank you. Are we in the country? No, before the one before. That one. Okay, thank you. Here's the breakdown of the $8.8 million distributed among the countries. The recipient countries were Antigua and Barbuda, Barbados, British Virgin Islands, Dominica, Grenada, St. Kitts and Nevis, St. Lucia, and St. Vincent and the Grenadines. And next one, please. This graph is just to show you the level of implementation of the funds received by our organization for the different countries. As you can see, the implementation levels were almost at 100% in every case, indicating that all funds received were fully spent in support to the COVID-19 pandemic. Next slide, please. Here's the same $8.8 million mobilized from donors, but shown by implementation levels in each of the recipient countries. As you can see, all countries had almost implemented fully these funds. The overall implementation level reached for all these countries was 98%. Next slide, please. This graph summarizes the resources mobilized and implemented by pillars. As you can see, Pillar 6 related to infection prevention and control, and Pillar 7 for case management had the greatest expenditure levels. As Dr. Paulson mentioned, these funds were used mainly for the procurement of PPEs and medical equipment, and The other higher implementation was for Pillar 3 for surveillance, rapid response teams, and case investigation, where we supported in strengthening the surveillance teams by hiring additional personnel and procurement of vehicles and IT equipment. Next was Pillar 10 for the vaccination activities, and Dr. Paulson and Dr. Omer already went in detail the support provided in this area, as well for other areas in the different pillars. So I will now go over them. But it wouldn't be fair not to say that some of these pillars are underrepresented in this graph because we are not including the human resources component that the organization had devoted in support to the implementation of these pillars. If we add that contribution, then the graphs would show a higher contribution from the organization in response to the COVID-19 pandemic in different pillars, particularly in Pillar 1 of leadership, coordination, planning, and monitoring, and Pillar 8 of operational support and logistics. Thank you.
Thank you so much, Patricia Cabrejo. It is important that we understand how the funds are spent and exactly what the response is and the contribution by the Pan American Health Organization to COVID-19, of course, in the Eastern Caribbean countries. As usual, I know we have a lot of information within the time period for these webinars, and we are about to take your questions. And I do have a few questions that came in before we did Dr. Taylor and Dr. Paulson and also Patricia Cabrejo. And I do want to start with a question that I've had pending for quite some time. And it is from the Honorary Consul of Italy. And she asks, she says, initially we were told that once we reached 70% of vaccinated population worldwide, we will have been protected. Many countries are now in the 3rd and 4th booster stage, and yet vaccinated people still contract COVID-19. Some end up in hospital and some still die. Why does the bar keep moving? I think that's a very important question. That is a question that many are asking. I am not sure which one of you would take this one. Maybe you all have your own answers.
Hi, Nicola, I could start, and I guess my colleagues could complement.
Go right ahead.
I think one of the main things that we have been saying and we need to remember is that vaccines, the main function of vaccines at the time is to reduce the severe form of the disease, to reduce hospitalization, and to reduce death. And we have seen this with the vaccines. And if you look at the chart that Dr. Singh presented earlier, it was clear that hospitalization has reduced and death. But COVID-19 vaccines and compared to other vaccines is not necessarily preventing you from getting the disease, especially when the acceptance has been so low and we're getting new variants. I mean, if we have reached that 70% earlier, we would have a different scenario. So we have seen in many studies that the vaccines are being effective for that main purpose when it was created, which is to reduce the severe forms, hospitalization, and death. Back to you, Nicola.
I've got one more question for you, Dr. Taylor. Earlier on, Danella, and I think you may have mentioned it when you were doing your presentation, but she asked, she says in the Caribbean, there are very few vaccine choices. Do you believe the lack of vaccine choices are affecting the increase in vaccine hesitancy? Dr. Taylor, are there very few vaccine choices in the region?
I personally, I mean, few is a very subjective word. To me, having 3 and 4 options is not few, especially in a context that some countries only have 1. So I would tend to think that would not be the main issues. We know at some point a lot of persons were hesitant with the AstraZeneca vaccines, and when now countries have Pfizer and Moderna, and some even have Johnson, we saw increase a bit, yes. But I would sit in the position that they have most countries in the Eastern Caribbean, if not all, have more than 3 options of COVID-19 vaccines at the moment.
Dr. Taylor, thank you so much. I've got another question from Janika Simon. She says policymakers around the region have been pushing vaccine uptake as the solution to the pandemic, at least its acute phase. With hesitancy and refusal so entrenched, how then can this stance gain any traction? Is it time for us to begin to figure out how to keep our population safe, even despite such anemic vaccine uptake? Dr. Taylor, I think you're in the hot seat this morning.
I'm going to start, but I'm sure one of my colleagues would talk a bit about how to address the pandemic. But we've never said vaccine alone can do it. Unfortunately, we rely on all the other public health measures that we have been promoting since the pandemic. So vaccine is just one important pillar. But if this is not complemented with all the other public health measures, definitely we would not see the same effectiveness as we would wish. And we know in general, some part of the population are complying, but there is a lot of persons that are not complying with the public health measures. And I think that we need to remember that the fact that you are vaccinated, you still need to protect yourself. Over.
Thank you, Dr. Taylor. Another question here from, I believe it's Frederic Dorleans. I hope I pronounced it correctly. He says, I have another concern regarding vaccine hesitancy and refusal. Is there a common and regional assessment of the situation? What are the PH measures implemented as we are facing massive refusal in the French Caribbean?
So yes, we've done, as PAHO, we've done several regional surveys to better understand the vaccine hesitancy issues, to better understand which are the groups and which specific age and sex. So we have an idea of where it happened. We did one specific also to healthcare workers. Recently, as part of a UN joint initiative to support vaccine hesitancy, also, I believe it was last week, Friday, UNICEF presented the results of the second regional survey on vaccine hesitancy. And we have also supported specific studies in countries, because we know we have a regional view, but there are times, especially in countries with low coverage, we thought maybe there were some specific things in those countries that we needed to better understand. So there are countries that we also did special analysis to determine what are the factors. And then we have designed the campaigns based on this information. Over.
Thank you again for that answer. Last question. David Johnson says, can you speak to the questions of quarantine period in the context of Omicron, particularly for contacts of confirmed positive cases? And he also asks, what is the science behind the calculations of the global target? Dr. Gieber, I see you're on the floor. Will you take this one?
Sure, why not? The first question about the quarantine period, some countries are choosing to reduce the length of quarantine or isolation given a large increase in COVID-19 cases. As you know, the Omicron is highly transmissible, and then they started to see a significant number of cases a day. So they will not be able to continue to manage with the day-to-day functions in workplace or hospitals, etc. So WHO advises that any adjustment balance, it has to balance the public health risk and benefits against its social and economic impact. Therefore, we are looking at some studies, ongoing studies, whether the incubation period or the length of infectiousness. We have seen from Omicron, some people are being infected within 2 days, 3 days, a very short period of time. So, and then once it happens also, whether these individuals will be infectious for how long. We have to know all those information before a clear change in terms of quarantine period. As of now, we do not have concrete evidence to support or change the WHO advice. The WHO recommendation is quarantine period is 14 days. This is based on information on the incubation period of SARS-CoV-2, and then which countries may choose to shorten by testing throughout or at the end of the quarantine period. So whatever countries are taking, it is based on their assessment. For us, from WHO PAHO perspective, we recommend a quarantine for 14 days or isolation also at least for up to 10 days and followed by another 3 days from the end of the symptoms. Back to you. Thank you.
Dr. Gibre, I know that we're running behind time. There is just one portion of this question, the science behind the calculations of the global target. Do you want to give that a shot? And also, given our time factor, do you also have any closing comments?
I should have given again the chance to Dr. Omer. Let me start and then I will ask her to jump in. The 70% target of the global target meaning that all countries, which are 194 countries of WHO member states, to make to reduce the susceptible population for SARS-CoV-2. If we reach at least 70% of the population with vaccination and also with infection, we would be able to reduce the impact of COVID-19. So what does that mean? That means also it's based on modeling, based on some studies, small studies showing that what will be appropriate level of immunity where we can have the lowest transmissibility period and the impact in society. So that was based on the studies we have. But if we continue to have low coverage for vaccines, we're going to have more infections and new variants coming. So that 70% may also have to be moved and shifted to a higher percentage. So for now, in order to make this COVID-19 controllable, under control, and then to end the emergency phase, we have to have population coverage of 70% through vaccination. Back to you, or immunity.
Thank you, Dr. Gibre. I must apologize. In the first session, or question and answer segment, Nisa Tyson, she actually had her hand up and she wanted to ask a question. So I'd like to open the floor for Nisa. Nisa, do you still have your question?
Okay, probably not.
Okay, thank you nonetheless, Nisa, for asking that particular question. All right, it is time for us to wrap up. I know that we plan to go from 10 a.m. until 11:30. We're 15 minutes way ahead of ourselves. And Dr. Gibre or Dr. Taylor, I'm not sure who would give the closing comments, or if you would like me to close for you. So on behalf of everyone, thank you so much for participating in this webinar, of course, where we took a look at ending the acute stage of the pandemic in 2022. And we took a look at the state of COVID-19 in Barbados and the Eastern Caribbean countries. We still have a long way to go. It is important that we all stay safe, get vaccinated, physical and social distancing, wash your hands, make sure you follow the guidelines, the policies in each of your countries, and let's kick COVID-19 to the curb. I know we're all tired of this, but I'm pretty sure there is some light at the end of the tunnel. So thank you all. Have a wonderful day, and we shall see you again soon. I'm Nicola Barreto.
Okay, bye-bye. Thank you.
Thank you. Bye-bye.
Thank you. Bye.